Right. Good afternoon, everyone, and welcome to Grand Rounds. We're very fortunate today to have an interstate speaker, so it's my great pleasure to introduce Professor Deborah Williamson. Deborah is a clinical microbiologist and she's the director of the Victorian Infectious Diseases Research Laboratory. She's also a professor of public health and is the laboratory director of the Infectious Diseases Department at the Doherty Institute. So today she'll be speaking on laboratory advances in the detection and surveillance of sexually transmitted infections. Thank you, Deborah.
Thanks. Just checking that you can hear me and see my slides.
Yep, we can hear you well. Thank you.
Thank you. Thanks very much for inviting me to talk at your Grand Rounds today. I'd just like to start by, I guess, acknowledging the traditional custodians of the land on which we're meeting today, wherever we are, and pay respect to elders past, present, and emerging. I'm actually going to talk more broadly today about some novel approaches to, I guess, preventing and controlling sexually transmitted pathogens. And I'll just preface this by saying that the work that I'll present is on behalf of a huge team of people who do this, including our very, very close collaborators at the Melbourne Sexual Health Centre, a team led by Professor Kit Fairley. So I'll talk a little bit about emerging and re-emerging STIs, how we've applied genomics to STIs, some novel diagnostic approaches we've taken with the recent Mpox, formerly known as monkeypox, outbreak, and some novel approaches to preventing STIs. So I guess the factors that drive the emergence of STIs, and you know, you'll be, I guess many of you will be familiar with this, with the recent emergence of Mpox. You know, they're multiple, these factors are multiple, they're complex, and they're often context specific. And we wrote about these a couple of years ago. And if you think about it, there have been some, I guess, STIs that have, I guess, non-classical ones, if you like, that have emerged over the past few years. So Shigella is a key example of that. You know, not something that we would traditionally think of as an STI, but which has very successfully found its way into sexual networks. And as I mentioned, these factors are complex, and they're driven by not just the bug, but the environment, I guess some sociological contexts as well, international travel, access to biomedical interventions like PrEP, and the host as well. So that classic epidemiological triad, if you like. I'll start by talking about gonorrhea. Obviously still a major public health problem. It is the archetypal superbug in that it has successfully developed resistance to every class of antibiotics that's ever been thrown at it. Coupled with that, the incidence of gonorrhea has continued to increase in many countries, obviously with a little decrease due to the pandemic, but it is starting to tick up again. And it's really quite an unprecedented increase, you know, over when you zoom out and look at, you know, the turn of the century to now, it has been a kind of inexorable increase. So genomics is one tool that we can apply to look more closely at the gonorrhea epidemic, if you like, and applying genomics to gonorrhea isn't new. You know, people have done it, including our group, for a number of years. But what they've largely done is to focus on the kind of big picture, the evolution of gonorrhea, and also on antimicrobial resistance. So I'll present some work that we did a few years ago now, actually, where we wanted to look at using genomics to understand at a much more granular level how gonorrhea was being transmitted within Victoria, including antimicrobial resistant gonorrhea. So we performed whole genome sequencing on over 2,000 gonorrhea isolates, and we integrated that with epidemiological data. And we identified different transmission clusters of gonorrhea. And that was based, I won't go into too much detail, but that was based on how closely related the genomes were. I'll just talk you through this here, and I'll try and use my laser pointer. But these different lines here represent different genomic clusters. So each horizontal line is a different cluster. And what you can see is that most of the data set grouped into clusters. So there were some single ones here which weren't related to anything. So about 80% of the data set grouped into 161 different clusters. Mostly these clusters were relatively small, so they just had the median was 3 cases, but I hope you can see here that some clusters, for example, lasted the entire year. And I guess when you think what that means conceptually, that's the same strain of gonorrhea transmitting within a very tight network over the course of a year. And of course, we only looked at a year, and it may be that it extends much further, either retrospectively or beyond that date. Now, I mentioned that we integrated epidemiological data, and this is where the real kind of granularity comes in. So these are the different clusters here with the number of isolates here. I won't go into these technical details, but the take home from this is when you integrate the epidemiological data, you can start to see where these different strains circulate. So for example, these 3 large networks here were predominantly, but not exclusively, within men who have sex with men. And these networks here were circulating largely in a heterosexual population. What does that mean from a public health perspective? Well, you know, from public health interventions, including health promotion, you know, I'm sure you'll all be aware that there's not a one-size-fits-all, and so you can start to tailor your public health interventions and messaging around, you know, where you know these networks might be emerging and spreading. Also here, when we look at antimicrobial resistance, we can see that some networks are associated with different antimicrobial resistance patterns. And again, you know, that's useful when you think about empiric treatment in different networks. So that's just one example of how we applied genomics to gonorrhea. Using the same data set, we also looked at whether gonorrhea was largely imported or whether it was due to local transmission. And essentially what we found was that of clusters where there was where somebody had traveled overseas, in around half of these clusters, that person was the first person in the cluster. So what does that mean? Well, there are some public health implications for people who are coming back overseas who may have either symptoms or may have participated, I guess, in high-risk activities overseas. You might want to think about better health promotion around screening or rapid identification of people with symptoms who come back from overseas. So those data were from about 6 years ago now, and what we wanted to do was to update this. So this is the data set from 2017, and then we started sequencing again in mid-2019, and we took that all the way through the pandemic to mid-2021. And our key question here was, do certain I guess lineages of gonorrhea persist over a very long time period, or do they die out? And I guess this is an extension of the previous diagram, where you can see that these lines here represent the same lineage persisting over a number of years. And you can, you know, again, conceptually, you can sort of think of multiple time points, if you like, here for public health intervention to try and shut these clusters down. This just shows that the longer, not unsurprisingly, the longer the duration of the cluster, the larger the cluster. But we were surprised, I think, to find that some of a proportion of these clusters really did persist over many years. And I'll skip that one. Okay, so what I guess the pandemic showed us is that there is a huge appetite for self-testing. And, you know, this was not something that was done in Australia prior to the pandemic, except actually for HIV testing. So there was one approved HIV self-testing kit. but having said that, with close linkage into medical care. But the pandemic really opened a Pandora's box, if you like, for self-testing for infectious diseases, but with many advantages and benefits to self-testing, in as much as, you know, it democratizes in a way access to testing. And this sort of slipped under the radar during the pandemic, but the TGA actually passed a legal instrument to approve the legal supply of a number of self-tests for infectious diseases, including some STIs, namely chlamydia, gonorrhea, and syphilis self-tests. And that it's actually quite an interesting document on the TGA website. So these tests are they are able to be legally supplied as long as the TGA evaluates them and ensures that they're fit for purpose. This was a paper from last year looking at a molecular self-test, actually a PCR self-test. It's not cheap. I think it's about $90. It's not available in Australia yet, but this was an overseas study essentially showing that it had pretty good sensitivity and specificity compared to the PCR tests for STIs that we traditionally do in a laboratory setting. And so these are definitely on the horizon, and they will change the way that we diagnose and manage and control infectious diseases. There is no doubt about that. One thing that's sort of come into vogue over the past 5 years or so for gonorrhea is something called resistance-guided therapy. Now, at the moment, the management of gonorrhea is very much empiric. So if somebody comes in with symptoms, they get very broad-spectrum antibiotics. And when you think about it, giving, you know, ceftriaxone and or azithromycin, I mean, you wouldn't sort of indiscriminately, well, I don't know, it depends on where you work, but, you know, giving that out, I guess, you know, in a hospital setting, it's, you know, not something that we would advocate under the antimicrobial stewardship umbrella. But in a community setting, you know, these are given extensively, these broad-spectrum antibiotics are given extensively for empiric treatment of STIs. So resistance-guided therapy is very much focusing down on not only this patient has gonorrhea, but B, what can we narrow the treatment down to? And the key marker that's looked for here is the GyrA gene, which indicates ciprofloxacin resistance. And this is being used, this approach is being used in a trial in Melbourne at the moment. So for example, if somebody has the gonorrhea and does not have the GyrA gene detected, then they will be given ciprofloxacin, which is much, I mean, it's not strictly narrow spectrum, but it's much less broad spectrum than the alternative. I'll just quickly mention a study that was done that we did a couple of years ago now, looking at novel approaches to the prevention of gonorrhea, which was using mouthwash, daily mouthwash, for the prevention of oropharyngeal gonorrhea. And this was led by Eric Chow at Melbourne Sexual Health Centre. In essence, it was a randomized, a blinded randomized control trial with two arms. One arm, patients received the biotin mouthwash, and the other arm, patients received the Listerine mouthwash. And essentially, it was a negative finding in as much as neither mouthwash reduced or prevented the acquisition of oropharyngeal gonorrhea. This was important because there had been a lot of literature looking at, or suggesting, I should say, that mouthwash may be useful in the prevention of oropharyngeal gonorrhea. All right, when I mention oropharyngeal gonorrhea, it's something that is thought of as increasingly important in the transmission of gonorrhea. A, because it is often asymptomatic, and B, it's also a reservoir for resistance as well, because in the oropharynx there are a lot of commensal organisms that gonorrhea, Neisseria gonorrhea, may exchange genetic material with. And so it's increasingly important as a site where you would want to prevent gonorrhea. But we don't understand very much about oropharyngeal gonorrhea. One of the ways in which we better or can improve the understanding of infectious diseases is through something called a controlled human infection challenge study. Professor James McCarthy, who's here in Melbourne, has set up an inpatient unit for human infection challenge studies at the Doherty here. And one of the first studies that looked at this, not in the Doherty Centre, but at MCRI, looked at, I guess, pharyngeal infections, was Andrew Steer's group, who looked at a controlled human infection challenge model of group A streptococcus. Have got some fascinating insights into the pathogenesis of group A strep pharyngitis. So we've been working with them, and we got a grant to set up a controlled human challenge model of oropharyngeal gonorrhea. We're well progressed now in selecting a challenge strain, working it up and putting together a clinical protocol for this. And what that means is that we can really start to look at the pathogenesis of pharyngeal gonorrhea, what the immune responses are. When we think about immune responses, that extrapolates out into vaccine responses as well. We can look at novel antimicrobial therapies, and we can also, I guess, look at mouthwash again. So I won't go through this in detail, but essentially we're hoping to have a controlled human infection challenge model and this will be a first in field. There isn't one globally for this, but a controlled oropharyngeal human infection challenge model within the next 3 years here. All right, I'm going to move on to syphilis now, and this is a really hot topic. It's we're seeing the emergence of congenital syphilis, certainly here in Australia, and for me, during my medical school teaching, I was always taught that the emergence of congenital syphilis was associated with, some marked breakdowns in public health, it's a major red flag, or should be a major red flag to public health bodies, that we're seeing this kind of 19th century disease in the 21st century. Anyway, so it's important to understand a little bit about the biology of Treponema pallidum, which is a causative agent of syphilis. So it's a very small bacteria. You can't see it under a microscope, and it has it doesn't grow on agar plates like Neisseria gonorrhea. So it doesn't grow using standard techniques. It's got a really, really small genome for a bacteria, only about 1 million base pairs. Why is this important? Well, it translates into a number of features that are I guess phenotypic and important for diagnosis. Because it's got a small genome, it doesn't have things like plasmids, and it does remain very sensitive to penicillin. Because of the small genome, it's got very limited proteins on its cell surface, and that means it's really good at evading host immune responses. Because it doesn't have a large genome, it doesn't contain enzymes which will detoxify reactive oxygen species, and that means it's really sensitive to oxygen, and therefore, as I mentioned, doesn't grow in traditional culture. And it's also very intolerant to heat. And actually, one of the historical therapies for syphilis was to either put people in a very hot room or put them in a very hot bath, so heat therapy. So I mentioned that it doesn't grow on an agar plate, and the very, very traditional way of growing syphilis is in rabbit testes, and unfortunately we don't. I said fortunately, not unfortunately. Fortunately, we don't use that anymore. There are some groups who are working on a cell culture system, but that hasn't really translated into widespread use. But one of the newer ways of looking at syphilis is PCR testing rather than serology. and lots of different ways of looking at, lots of different targets, I should say, for looking at Treponema pallidum using PCR. It's very specific, but the sensitivity of this test really depends on the sample type, the stage of disease. Why is this important? Well, this is a study that we did a couple of years ago to look at whether syphilis was really a kind of multi-site systemic disease, and therefore was Treponema pallidum shedding from multiple different sites. Classically in medical school, you're taught that people with secondary syphilis who've got lesions, that's the really infective part. But what we wanted to do was actually to look at areas where there weren't visible lesions. So again, the oropharynx, the rectum, saliva, and see whether or not we could detect Treponema pallidum in those sites. I'm not going to go through this in a huge amount of detail, but the take home here is that we detected Treponema pallidum at all of those sites. Not just your genital sites, not just lesions, but in the oropharynx, in the anorectum, and also I haven't shown here in saliva as well. But this was much more prevalent during secondary syphilis, so that kind of systemic part of the disease. Why is that important? Well, again, it improves our understanding of the way that these diseases are transmitted. So, just because somebody doesn't have visible lesions doesn't mean that they're not transmitting Treponema pallidum. I'll talk a little bit about applying genomics to Treponema pallidum. I mentioned you can't grow it on an agar plate. That makes doing genomics really difficult because we have to then sequence directly from clinical samples. And we've developed a method for doing that whereby we pull out anything in the clinical sample that looks like Treponema pallidum using what we call them baits. We pull those baits together and then sequence them. And we did that earlier last year. So we looked at the different Treponema pallidum lineages within Australia. And this was important. I think this was important because, we've heard a lot about the syphilis outbreak in Australia, and there is an epidemic of syphilis in Australia. There's no doubt about that. But what we didn't know at the time was whether or not that outbreak was caused by just one circulating strain of Treponema pallidum, or whether there were multiple co-circulating lineages of Treponema pallidum circulating amongst different groups, similar to what I showed you for gonorrhoea. And again, I mentioned that's important because you might tailor your public health interventions. So again, we sequenced about 500 samples from Australia. We could textualize that with everything that was publicly available internationally. Again, I won't go through this in a huge amount of detail, but a few key take homes here. So this is something called a phylogenetic tree, and essentially these are all the Australian genomes here. We looked at some from Victoria, and we worked with our very good colleagues in the Northern Territory to look at some Northern Territory samples as well. Interestingly, they were largely interspersed throughout the Australian phylogeny. The main points here is that the syphilis epidemic in Australia is not caused by just one lineage of Treponema pallidum. There are multiple lineages that are co-circulating, contributing, if you like, to that kind of cumulative epidemic. The modern strains, or the strains, I should say, of syphilis that are circulating in Australia at the moment have largely emerged since the turn of the century, so in the 21st century, and they are highly related to lineages that are circulating globally. So it's likely that most of these Treponema pallidum lineages were imported into Australia and then expanded throughout those sexual networks that I showed you previously. And then when we integrate some of the epidemiological data, we can see these are different clusters, if you like, of syphilis here. Again, largely associated we think with male-to-male transmission, although not exclusively here. This is one lineage that is circulating amongst the heterosexual population. It comes back again, I keep coming back to that point around a deeper understanding of the way that these pathogens are transmitted will enable tailoring of public health interventions and ultimately better use of public health resource. All right, I'm just going to finish briefly by talking a bit about Mpox. And, it's rare, I guess, that you get a totally new STI. And this blindsided many of us. Not so much that it emerged, because it was, it's been endemic in Africa for a long time. But I guess, it found its way successfully into very successful networks that enabled its rapid emergence and spread. So there are now well over 80,000 cases reported in 110 countries where Mpox was not known to be previously endemic. It's a very large virus, nearly 200,000 base pairs, and we diagnose it at the moment almost exclusively with PCR. Other methods like antigen tests and antibody tests, at the moment they lack sensitivity and specificity. So one of the things that we do as a reference laboratory is when we get an emerging pathogen, we like to, I guess, understand how well our diagnostics perform. Often when there's an emerging pathogen like a SARS-CoV-2 or Mpox or the monkeypox virus, you'll see a kind of a lot of commercial assays quickly come on the market, but often we don't know how well they perform. So one of the things we do as a reference lab is to rapidly look at those and then help inform which test might be rolled out, in other laboratories. And that's important because it's increasingly recognized as being important when you have an emerging pathogen. You can't just centralize all of the testing, and the COVID is like the exemplar of that. You can't just have the testing concentrated in some laboratories. It's decentralization of testing, obviously dependent on the context, is far better. And so we looked at a range of different assays for Mpox and found that actually the commercial ones that came on the market were pretty good. We also looked actually at whether or not there was a difference in the amount of virus in different anatomical sites. And what we found was that essentially there's not a particularly technical way of putting it, but people who had Mpox lesions, they were like chock-a-block with virus. They had very, very high viral burdens in those lesions, but also very high viral burdens in the anus as well, less so in the throat or the nose and the nasopharynx. And it just reflects the fact that Mpox is a systemic disease. So it's not just a dermatological disease, it's a systemic disease. We looked at whether we could culture the virus from those lesions. And what we found was that actually it was pretty easy to culture. And why is that important? Well, we found a kind of CT cutoff, and some of you will be familiar with hearing about CT values for COVID, but we found a CT value of about 32 meant that we couldn't culture it. And then there's a sort of school of thought that you might be able to extrapolate that into whether or not the virus is transmissible at that CT level. Why is that important? Well, you might have somebody in isolation, and if you're serially monitoring their CT values, and it goes to up to 30 to 32, 35, you might reasonably say, okay, well, they've got a bit of DNA that's hanging around, but we know that they are not shedding live virus. All right, I'm going to finish there, just to say that rates of STIs are really approaching levels not seen for many years, with this emergence and re-emergence of non-classical STIs, with Mpox being the absolute exemplar of that last year. We can't test our way out of an STI epidemic. It's a multifaceted approach that includes, diagnosis and biomedical prevention, but probably the most important thing is timely access to testing and treatment. Sequencing is useful. It's not a panacea, but it's very useful in that we can track the emergence and the spread of STIs, both locally and globally. And as I mentioned, the cornerstone of STI control is access to testing and treatment. And lots of acknowledgements, and particularly my lab group who've been working on this, but most importantly, Melbourne Sexual Health Centre, a world-class team there, and also to all of the patients and individuals who've contributed their time and their samples to this work. So thanks very much.
Thank you very much, Deborah, for that wonderful overview and presentation. I'm going to actually take the opportunity just to ask the first question. I was wondering, when you mentioned the importance of decentralisation of all the testing, which makes perfect sense, and particularly, I guess, in a country like Australia where we're spread so far and we have all these smaller regional hospitals and so on. And I guess with regard to, things like the sequencing and the resistance-guided therapy that you were talking about, is that technology, is that kind of, is that available and realistic to be used in the smaller regional hospitals now? Because I guess we need to be having not only the tertiary care referral hospitals being able to really streamline the antibiotic management, but kind of all the smaller hospitals as well.
Yeah, that's a really great question. So at the moment, sequencing is available in all of the public health laboratories across the country, and there's been a huge concerted effort to make that happen. But the resistance-guided therapy, that's an excellent question, and at the moment that is not available outside of large laboratories, and indeed it's not something that is widely used across the country. Having said that, companies like Safed, who manufacture the GeneXpert technology, they are looking at cartridges for gonorrhea, where you would be, and actually one for Mycoplasma genitalium as well, where you'd be able to rapidly guide treatment. And there are some other tests on the market. There's a researcher called David Wiley in Queensland who's been doing a lot of this work as well, and somebody from his group gave a very nice presentation at the Point of Care Testing Conference, which was in Sydney 2 weeks ago, looking at developing a kind of antigen, or a lateral flow test for rapid detection of antimicrobial resistance in gonorrhea. But good question.
Fantastic. So I guess it's a bit of watch this space for that, rolling that out more. And obviously the self-testing kits, are they well funded as well no, that's all just TGA approved and not funded. So I guess that's all emerging as well.
Correct, yeah.
I'm going to see if there's questions from the audience, and I can't see anything on the chat as yet. So please feel free to put a message on the chat. Is there anyone in the audience who would like to? Sarah?
Sarah Martin here.
We'll use the microphone. Hopefully Deborah will hear. If not, I can repeat. Yeah.
Thank you for that lovely summary of so many different issues. Are you able to talk to us a little bit about how you might move the information that you get from genome sequencing and identifying images into more tightly tailored public health responses?
Yeah, that's if I was hearing correctly, you're talking about translating the information from sequencing into public health responses. Yep. Okay. Yeah, that is a fantastic question. And so, for gonorrhea, I'll use the example of gonorrhea. What you might do is if you're able to do this work in, and I'm going to say real time, I don't mean as in real time, minute by minute, but for example, if you were able to look at this on a weekly or fortnightly basis, and you saw a cluster that was rapidly emerging and it was associated with AMR, then you know, that's something. And this work, just to be crystal clear, would be done in close connection with, you know, local jurisdictional public health unit. But that's something that you might want to get, you know, the contact tracing team onto pretty quickly, or you know, or you might want to tailor local empiric antibiotic prescribing practices. That was actually done in the UK, where a cluster of ceftriaxone resistant gonorrhea emerged in one network, and they, you know, they had a local incident management team. They changed their treatment. Shigella, I didn't present the work on Shigella that we've done, but again, that's another key example here where, you know, you've got the emergence of multi and indeed extensively drug-resistant Shigella in some sexual networks. And again, that's something that you would want to not just kind of stand back and watch, but you'd want to put your public health resources, whether it's health promotion around you know, not having sex for a number of days until your diarrheal symptoms are resolved, towards, you know, letting the local clinicians know that there is this outbreak of extensively drug-resistant Shigella, and, you know, not to give ciprofloxacin because it won't work if you've got, you know, a gay man coming in with diarrhea. So they're, I guess, the sorts of, I hope that answers your question, but they're the sorts of ways that you might translate the information.
Yeah, that's really helpful. And we have micro, public health and sexual health in the audience today. So we'll put together.
Yeah.
Thank you.
Do we have other questions from the floor at all?
There's an interesting question in the chat I can see here. Somebody's just asked about using the genomics to link people in a, I guess, in a forensic context as well. The answer to that is no. No, that's not, you can't, you're not, the technology does not allow for that. One of the key reasons for this at the moment is that the data that I presented there on genomic sequencing for gonorrhea, that's all based on isolates growing, on isolates where you have an associated bacterial culture. Now, in Australia, depending on where you are, only between 20 and 30% of all gonorrhea notifications are associated with a bacterial culture. The vast majority of gonorrhea is diagnosed on a molecular testing platform, and so the data that I presented there are, I guess, tip of the iceberg, if you like, in clusters, and so for every data point on one of those clusters, there'll be numerous other ones in between that we just don't know about. So absolutely not.
All right. Well, we do have another question. Would you just bring you the microphone?
Thanks a lot, Deborah. In relationship to the longevity of the gonorrhea isolates, the fact that these isolates existed for such, well, 2 or 3 years with a gap of testing, is that an indication of failure of our contact tracing, or just in the nature of the beast?
Yeah, I actually don't know. It's a good question, and the answer is I don't know why some of those clusters persist for such a long time. My own, you know, my own personal hypothesis about it is that, you know, you might have these very kind of tight sexual networks, and facilitating the kind of ongoing transmission. I'm not sure that it's a feature of the bug per se, but I think largely it would be, you know, behavioral and sociological. But the honest answer is I don't know. It's fascinating. I don't know.
All right. Well, I think is there another question? No? I think we might all then thank Deborah very much for this wonderful presentation. Thank you.
Thanks for having me.